So welcome, everybody. My name is Joanne King, for those of you who might not have met me before, and I'm currently the co-chair of the Ottawa Valley Ontario Health Team Steering Committee. And as many of you who do know me will know, I work with Barry's Bay Area Senior Citizens Home Support Services. And I'm really pleased to welcome everyone here today to this next installment of our mini series. I love I love our slogan, bite-sized information on big projects. That's really exciting. Today, we're going to get an update and have conversation about our CQIP, our Collaborative Quality Improvement Plan. And I really always want to start by really having our most appropriate land acknowledgement here. So on behalf of the Ottawa Valley Ontario Health Team, I want to start by saying that we want to start this collaborative partners forum this moment by acknowledging that we're meeting on Aboriginal land inhabited by Indigenous peoples since time immemorial, from the very beginning. As settlers, we are grateful for the opportunity to meet here, and we thank all of the generations of people who have taken care of this land for thousands of years. Long before today, as we gather here, there have been Aboriginal peoples who have been the stewards of this land. In particular, we acknowledge the traditional and unceded territory of the Algonquin Anishinaabe. We recognize and deeply appreciate their historic connection to this land, and also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community in particular, as well as our province and country as a whole. As settlers, this recognition of the contributions and historical significance of Indigenous peoples must also be clearly and overtly connected to our collective commitment to make the promise and the challenge of truth and reconciliation real in our communities, and in particular to bring justice to missing and murdered Indigenous women and girls across our country. Miigwech. And then I think I hand it back to you, Lisa.
That's great. Thank you so much, Joanne, and thanks for being able to join us today. And I welcome everyone that's here on the call. For those of you who haven't met me, my name is Lisa Hawkins, and I work a joint role. Part of it is as the primary care transformation lead for the Ottawa Valley OHT. But it really is the other hat that I wear that brings me here today, which is my quality improvement and decision support with family health teams in the Champlain region. So I like to talk about all kinds of things that have to do with quality improvement. And so before we get into the meat of the CQIP, I wanted to start with this slide, which talks about something that I can talk about for a very long time, but also was brought up at a webinar some of you might have been at a couple of weeks ago on quality improvement in primary care, where Dr. Noah Ivers spoke at length around how we're always so busy and we're in the business. We have endless inboxes and we have a waiting room full of people, and we don't have time for quality improvement. We don't have time to work on the business because we're too busy in it. And so sort of like that classic example here on the slide, I mean, we don't have a chance to figure out, are we doing the most efficient work? Are we improving access? Is there a better way to do what we're doing? Because we're so busy doing it. And so just as indicated, sometimes we get stuck on the square tires when obviously the circle tires would make much more sense. We don't even have a chance to try them out. So that's, I like to think of the CQIP in that way, in the sense that it is a collaborative quality improvement plan that we are mandated to do as an Ontario Health Team, but it also is an opportunity, I think, for us to work on the business. It gives us a chance to actually look at what we're doing and be very responsive as opposed to reactive. And we can actually look and see, we have a chance to put things in place, try them out, measure them for success, look for challenges, and adjust as needed. So For sure, this is a quality improvement plan that is due at the end of March. I know many of you in your sectors are working on them as well. So it is a document in that sense. But I think we're really good here at OVOHT at continually bringing quality improvement initiatives into the work we do and looking at things through that lens. So I hope that we can sort of keep that in mind as we go through this presentation and as we continue working over the next year. There's a lot of content in this presentation, so I'll go through it pretty quickly, just so you have a little bit of information in regards to where we've come from and where we're going. I will save some time, hopefully, for some questions. And I'm always happy to chat quality improvement anytime. So certainly happy to take some questions offline if we get short on time. So important to know around the collaborative quality improvement plan. One of the wonderful things about it is that so often we work on quality improvement initiatives in our sector, right? We're working on them in primary care, we're working on them in the hospital. But this really is an opportunity for us to bring sectors together to work on something, which really allows us to move the needle in a way that can be quite difficult when we're working in our own little pockets. And so our priority populations, as many of you know, for this OHT are mental health and addictions, chronic illness, frailty, and then primary prevention. And the CQUIP populations really just are subpopulations of that. That's where you're seeing mental health in the emergency department, you're seeing ALC, and you're seeing cancer screening. So like many other quality improvement plans, ours consists of 3 parts. We have a progress report. That's where we report on what we did or said we were going to do last year and sort of highlight our successes and indicate any lessons learned. There's a narrative where we get to talk a little bit about our OHT, quality improvement successes. There's also a section on attaching unattached people to primary care. And then we have a work plan, which is where we get to lay out some of the change ideas and indicators we'd like to work on in 2024-25. So from last year, there are some priority indicators that OH would like us to work on. And one of those is ALC. So the alternate level of care days expressed as a percentage of all inpatient days. And we do very, very well on this indicator. Coming in, we're at 15.2% into this fiscal. And you can see that at the end of fiscal, we're at 10%. Now, the little box at the bottom, where possible, what I've done is compared us to the province and then also compared us to 2 similar OHTs. They're not exactly the same, but also rural have a similar profile. And so as you can see here, we're doing much better than the province and much better than the other 2 OHTs. So we did have a change idea here in regards to warm transfer. And the big win really was the integration of Ocean into CareDA for a primary care Ocean referral to community support services. There was a mini series a couple of weeks ago explaining sort of the tremendous work that's done in that area, so I won't speak too much about it. But I would say that that was a really big win from this past year. We all work in with platforms that don't talk to each other. We chart in platforms that don't talk to each other. So having that integration is huge, and it really allows for primary care to refer to community services, which is just not something that happened very often before. So this is tremendous news. The next priority indicator is around the first point of contact for mental health and addictions related care. And so so there are some challenges with this indicator, and I won't go into depth on that, but I can say collecting the data can be quite difficult, as this really depends on provincial repositories. So we have OHIP data and billing data, but we don't know things like access to community services. So just keeping that in mind. Our performance was 25.5%. We didn't expect to see an improvement here again, because it is a bit of a challenging indicator. We did go up to 31%, but we are very similar to the comparing OHTs. So what we really were promoting was looking at, can we really use Access MHA as a local solution for straightforward access to referral and intake for mental health and addiction services? What we were able to do was really look at which agencies are listed there, what is their referral components, what is available in OVOHT very much represented at Access MHA. But we recognize that accessing local Access MHA data continues to be an issue. So we will continue to have those conversations with Ontario Health. Now, this is an indicator that we did, a custom indicator. And this again is around the emergency department use for mental health and addictions issues. And so our change idea was around a work plan to review current practice and spread for the HEADS ED protocol. So HEADS ED is a quick assessment tool that's been developed by CHIO for children and youth 21 and younger. And essentially it provides a score which then will help the provider determine where to refer, sort of the severity and what services are required. And then we also wanted to look at the ED diversion for addictions issues to community withdrawal services across the emergency departments. And I can say 100% of our hospitals have adopted HEADS ED over the last year. So that's tremendous news. I'm not sure if Molly is on the call. I was hoping maybe she could comment on the HEADS ED protocol if she's here.
Yeah, I'm here, Lisa. Thanks. So yeah, the HEADS ED, Lisa kind of explained what it is. So it's just an easy way for clinicians to implement a screening tool. It tracks 7 domains. So home, education, employment, activities, drugs and alcohol, suicidality, emotions and behaviors, and discharge and current resources. So our pathway here in Renfrew County is throughout all the hospitals. And our crisis team are actually the clinicians who facilitate the, sorry about that. They're the clinicians who facilitate the assessment. And from there, we have a pathway that's either deemed, inpatient treatment, 24-hour response with resources, 7-day response, or home with some resources. And we partner with the Phoenix Center to help implement that.
That's wonderful. Thanks so much, Molly. So that was something we hadn't been able to get in place, and keep that in mind. Actually, that's a bit of a sneak peek in our plan for this next coming year as well. So another custom indicator was again around using digital tools to support attached and unattached patients to get access to the right care at the right time. Again, this is very much around the e-referral platforms using CareDove and Ocean. So I won't speak too much to that, except again, huge success. And we did have 14 organizations hosting 320 services and programs that are involved in this integrated pathway, with both the provider facing, which I spoke of, Ocean, and then the client facing, which the Ottawa Valley Health Connect. And then our next indicator was number of unattached patients who access VTAC for support navigating health systems, as opposed to going to the emergency department. And right now, although this number will go up a little bit by the time I submit to OH, we have 9,835 unique unattached users who have had an encounter with a physician, a paramedic, or a hybrid appointment with VTAC. So the assumption there is a large number of those people have been diverted from the emergency department and been able to access the care they needed through VTAC. And then sort of as an arm of that, we have an indicator here around percentage of enrolled patients with access to team-based approach to primary care. And that's through IVC, the Integrated Virtual Care Program that many of you have heard of, that started out of Petawawa Centennial Family Health Center. And so this is a program where you are attached to a named primary care provider, and you have access to a comprehensive team-based primary care. And so although your primary care provider will work off-site most of the time, you will have access to a full complement of interdisciplinary health professionals, both in person and virtually. So it started in Petawawa Centennial with the plan to expand to both Pembroke and Deep River. And we have had 88% patient satisfaction so far. And Sarah's on this call as well, and she can speak a little bit about how that expansion has worked in Deep River.
So in October, we had a provider who closed her practice. We took on 3 IVC physicians who work the equivalent of 0.2 FTE each. They work entirely off-site and were able to roster just over 800 patients who would otherwise have not had a primary care provider. So they are able to see their IVC physician by video or over the phone, and we will support them to do that in clinic or from their home. And then those patients are also able to continue things like allergy shots or injections with our nursing team. They still have access to our social worker and our dietitian. And then also, if the IVC physicians need something seen in person, they consult with the MPs who are able to provide an in-person assessment. And then those patients, because they are rostered to IVC physicians, also have access to our urgent care clinic.
Perfect, thanks. Thanks, Sarah. And so since April 1st until now, between Sarah's team in Deep River and Petawawa and the Pembroke expansion, over 3,000 people have been attached through this program. So now we're back to the priority indicators. And so there's the 3 cancer screening into colorectal, cervical, and breast cancer screening rates. Many, you may or may not know, a big initiative for us here at OVOHT has been to collect local data through EMRs. So we have all the family health teams, the CHCs, 2 FOs actually contributing that data, and we do monitor it at a dashboard at the primary care network level. So we're really in tune to sort of any quality improvement initiatives that are going on. We're able to track that in real time, which is really exciting. The other thing we do is we really leverage the primary care network as a place that we can share quality improvement initiatives. Some great things have been done over the last year. Madawaska Valley and ConnectWell have had really huge success in putting resources towards increasing their cancer screening rates, looking at EMR data. So there's been lots of wins, and we make sure that we stay up to date with those and monitor those. Now, the data you're seeing here is the provincial data, just so that I could compare to other OHTs in sort of real time. And so colorectal is probably where we struggle the most here in OVOHT. We are doing better than the province, and we are doing better than the 2 other OHTs, but maybe not, we didn't increase our rate to the degree at which we thought. Mammograms, again, we're doing well, better than the province and the 2 other, Hastings and Lanark, Leeds, Grenville. And then finally, Pap tests, we're doing very well. And we saw a huge increase here. As some of you know, there was a delay in reporting and getting results back. And so that seems to have resolved itself. And so we've seen the rates go up. There's been a lot of initiatives going on to get those rates up as well. So a lot of hard work has been done to get people screened in a timely fashion. So moving forward, as I'm watching the time as well, we really want to build on the successes of this past year. And what I can say, and I already sort of hinted at it, is that, so sneak peek for the next slide, is that the indicators aren't changing for next year. So those 5 priority ALC, the first presenting of a mental health and addiction issue at emergency department and the 3 cancer screenings. Those continue to be the priority indicators for next year. And this is exciting because then we're able to sort of use work that we're already doing and build on it, right? And so that we're not having to start over again. And you're going to see in some cases like the HEADS ED, where we're going to be able to hopefully use something that we did really well and build on that. And so again, it continues to support that collaboration, the co-design across sectors, and we can focus on the same key areas. So again, I gave up the big secret. So the same 5 indicators, and of course, we're allowed to add any custom indicators we would like to measure as well. So far, looking ahead, we're starting to build the plan for 24-25. As I mentioned, ALC, we're doing really, really well. And so we don't actually expect to see that provincial ALC, we don't actually expect to see that improve dramatically, maybe not at all. But what we are going to do is implement change ideas that fall under that umbrella, and that's the places where we're going to see some change and we're going to see some wins. And one of those ideas is very much based on something another OHT is working on. And so they're using the clinical frailty scale at a primary care level, and they are building within their EMR functionality so that when the scale is completed and a score has been assigned, the EMR will tell the provider, this is where you need to refer the patient based on the outcome of the CFS. So this not only would be very helpful to primary care network, it really feeds into the other work that we're doing. We're already starting to work on a falls pathway, a single coordinated cross-sectoral, here's where you enter the falls pathway here in OVOHT. And so you can see that, you know, a score on the CFS that might be a little bit lower may fall exactly where on that new falls pathway. So you can see how they would really work together. We also, and again, this is already work that's already started, but we want to continue to work on creating a common, streamlined, and equitable local referral pathway for specialized geriatric services. So again, we want that single point of entry. And again, based on that score from the CFS, it could be that that's the referral that needs to be made. It's a bit higher, they need specialized geriatric services. And then fourthly, this work has started, is a coordinated hospital discharge for unattached patients. And again, these are all cross-sectoral. You're seeing a lot of people. You're seeing primary care in hospitals, home and community care, paramedics, mental health and addictions, a lot of people coming together to make this as fulsome as possible. Speaking of mental health and addiction, so again, for the first point of contact, I alluded to, it can be very frustrating because we don't have the data to tell us exactly whether it is the first point of contact or are they already involved. Let's say with the Phoenix Center or community mental health, are they seeing a social worker, a family health team? So one of the first things we'd like to do is start to look at the data at a primary care level, just to see if mental health is being coded, if it's being identified with an ICD-9, and if we're starting to see some billing based on mental health appointments, because then that becomes part of that provincial data source when we're looking at that indicator. And it was actually based on a conversation I was having about that idea with a physician, where they said, Lisa, but we don't actually know a lot about the people coming in. And we don't know, are they accessing community health services? Are they not? Are they attached to a primary care provider? And so, as I hinted at, because we have that protocol in place for HEADS ED and it's working so well, the idea is, could we attach a couple of extra questions around access to community services when that protocol is being used? And then if we can leverage students possibly to help with this idea, we may be able to see some trends. Are people showing up in the emergency department who have not accessed any services at all? Because then our approach is a little bit different than if we're finding that they do have access to community services, but for some reason they're still feeling like they need to be at the emergency department. And then again, the cancer screenings are going to be there again this year. So we're going to be monitoring them very closely at the primary care network. And so part of that is this is attached. So these are people who are rostered and attached to a primary care provider. And we've been working with the Champlain Cancer Screening Program, their outreach branch, as we've been trying to provide some PAP clinics for unattached people in the region. And but their other branch is for people who are attached to primary care. And so they're looking at ways to collaborate with the Ontario breast screening programs to see if we can block specific time for specific clinics. Can we attach PAP testing to those clinic days? Looking at ways that we might make it, you know, as easy and seamless as possible for people to access that the screening they need, and also for teams to identify the correct people within their practice to make sure they're getting contacted and getting an appointment scheduled. And then we were chatting about sort of a targeted communication strategy as many clinics want to share information and work. It would probably be helpful to have a bit of a toolkit, which includes possibly postcards or posters, snippets to share on the social media channels. So we're looking at a bit of knowledge and awareness campaign there. And then finally, we want to keep the custom indicator from last year around attachment to primary care and interprofessional team of healthcare providers, except we want to look at it this time in regards to how we use Healthcare Connect. We know that this is where people should be going to sign up for a primary care provider. But we don't know a lot about the practice of how that's working in OVOHT. So we really want to understand, is that where people are going? Is that a correct repository? Are providers picking up from that list? And start to understand and identify any challenges or barriers there. And that was a lot very, very quickly. So I did, as promised, leave a little bit of time for questions or comments. And we'll also leave you a little bit of time to complete a quick evaluation so that because we're in QI, we want to know what you thought of this and any comments you might have. Feel free to go ahead, Moira.
Sorry, I would be coming from a perspective of being a senior who is lucky enough to be attached to a family physician, but knowing that they could retire at any time. So it's all really, really helpful to know what's happening. I had retired 6 years ago and moved from Ottawa, and prior to that had been a part of the breast screening that every 2 years I would get a card and then be prompted to go through and do that. And because of my age, I think I might go one more time and then out to the university go. So my simple question on that is, would that data from Ottawa, even though I get it mailed here, would you be able to access that with your link to the Champlain program? Or is that sort of a separate entity that because I now live in the La Paz area, my data wouldn't be shared with you folks?
Well, so what I do know is that we will be able to know because you're attached, that information will be available to your provider. And so we would then be able to identify through their electronic medical record, how many, you know, are you due or not due? And then you would make the list for the phone call and then be part of that when you
Okay.
are. Yeah.
And a subsequent question was, years ago, my mom had been identified when I was in Ottawa with dementia. And I had been approached to be a part of the Canadian longitudinal study. And I'm just curious to see if the OHT has access to any of the data from the longitudinal study that is going on. And I think I went to Elizabeth Briere to have a full assessment to see how I did, probably 15 years ago. So it's just a question, you don't have to answer it, but it might be a neat thing to try to link up with, because they're tracking people right till the end of their day. Again, it should be through your medical record that there might be some interesting data there. And as a senior, this is really important. And so part of it, when you start to share it with people to get them engaged, telling a reflective story of a situation might help people process it, to understand, because you're using a fair number of acronyms and terms, which in the medical profession, you're all experts. But as a layperson, I write furiously to try and learn, but a story will stick with me and go, okay, this is really important. So just that's a tuck away. But thank you, you're doing great work. So thank you.
That's wonderful. Thank you. And I agree that the storytelling piece, being able to sort of personalize it in a way, I think that makes really good sense and will be helpful with our communication strategy. So that's helpful. I've made a note. Tina?
Yeah, thanks. And Maura, I agree with your statement around all our sectors seem to use a lot of acronyms, and I'm not in health, but I am in developmental services. And we've been talking with the hospital and partners around that alternative level of care and what that means when someone's hospitalized. And I think there's sometimes a misunderstanding about services like ours in terms of how we engage or how we're a part of a system, but not an ownership over a person in terms of someone coming into hospital. And I wonder if there's a table that we might be able to be of benefit to when we're looking at that specifically. And if so, if my name could be added to that.
Absolutely. Oh, that's great. Did you want to, Tina, did you want to just send me your email in a message in the chat, and I'll make sure that
Sure. Thank you.
get on the list. No, thank you. That's great. And Lisa?
Yeah, it's just this aligns so well with all the things that we have on our radar as well. It's just so nice to see the full circle from hospital to community, and that our priorities are all the same. I was just thinking, Moira, as well, our hospital has been trying to be a lead for seniors transition and care. But I know Melanie Henderson, who's our VP, we were saying really it's something we feel should move to the OHT as the lead, to say really, we've been trying to lead it as a hospital, but I don't know that we're the right leader. I think we need to be a partner in it. But so well, there's Melanie now. So anyway, we were just saying, you know, we think that it's time that we've gotten it this far. And now that we have an OHT really firmly established, working on a quality improvement plan, looking at ALC and all these different challenges, it's probably time to shift that leadership, but we would still be part of the group.
That's good. I have one more thought. It was, as you both were talking, it's about, and I also came through developmental services in my career. So I truly understand all the collaboration and the handoffs, the warm handoffs that need to happen so parents don't repeat their same story over and over. But as a senior, and I think as a human being, I would hope the system evolves, that I would feel that something is being done with me as a partner versus being done to me. And so there is a fear. I think I've seen it with a lot of our friends up here. When they get to that stage that they need more help, they don't want to take that next step because they're afraid of what they're going to be told and how they're going to be directed. And so there's more support that needs to be there to try to make it more normalized, that it's okay to need help, right? And I think we all need to do a better job of that as humans, but and as good neighbors, but it's okay. You don't have to feel that, you know, you can get Meals on Wheels and nobody's going to judge you because I've just had our grandchild here and I'm exhausted with cooking food. So I'd like a night off from cooking, and that normalizes it versus being you know, I'm really becoming not able to cope. And some people are, but there's a continuum. So,
No,
so
I
stay the course.
absolutely, and I think that's really helpful, and that's exactly, you know, how we do have to frame things, because that is, you're right, that is being human, right? I mean, we all need support from each other and need services for different reasons at different times, and it's very, very normal. And great to hear about that conversation, Lisa. So it sounds like something we can follow up on in this coming year, so that's great. And Marae?
Sorry, the click doesn't always respond. Yeah, it's thank you for the presentation. I'm glad to see that we're continuing to track indicators regarding the use of Access MHA, which is, while in Champlain it is in the 3rd year, it's still, I'm thinking, evolving. And as we know, it's also expanding to the Ontario East and South. So and that is happening in the context of sharing resource and still sorting out in short-term and longer-term funding and resources. So I think, yeah, just wanting to say that I'm happy to see that this is up there as an indicator that we need to continue to track.
And with that, once you're done the evaluation, you're free to go. I'm giving you back 3 minutes. So thanks everyone for attending. And again, feel free to reach out anytime if you have any questions or if you wanted to have further conversation. Always happy to chat.